Chowski, and myself, Dr. Tamara Hefferon. What are the objectives? It's really to give you an introduction and review of maybe just a little bit of the kinesiology and anatomy, and then start to help you with synthesizing, categorizing, evaluating that information that's coming from our patients through our initial exam, and helping to prioritize where we're going to go with our treatment. We're also going to try to give an accurate patient prognosis from our diagnosis and developing our appropriate plan of care. To do this and to help with this, we're going to talk about a case study as we go through the lecture today. We'll say our case study is about Maria. She comes in, she's a 55-year-old female. She is mildly overweight. She has that slow, guarded gait and posture, really just kind of slow with her movements. Her main complaint while she's talking with you is she's having some right ear, right jaw, right-sided headaches, also a little bit into her neck as well. She complains that at work, she works at a call center. She works really long hours. She likes to get as much overtime as she can because she lives at home by herself, and so she'd rather work, and she didn't really put away for retirement. So she complains that she starts to sit more, she starts to get more neck pain with that prolonged sitting. Her jaw pain increases when she's eating, and that can inhibit her ability to talk on the phone for her job. Current pain as she's sitting there talking to you is 6 out of 10. She says that it can get to a 3 out of 10, and that's the best after maybe she gives herself a self-massage. She has splurged and gone to a massage therapist every once in a while and tends to help her out. She can get up to a 9 out of 10 and getting some sharp pain into her ear after eating, really when she's eating more tough food and then when she has to go back to working. So she started to limit how much she eats, and as far as chewing a harder type of meal, so harder breads, harder meats, things like that have gotten more difficult for her. As you're sitting there watching Maria, you notice that her opening of her mouth is not very wide, and she has some restriction even with her cervical rotation. She's sitting in that forward head posture and really with absence of core stability as she sits through your initial examination. Let's just rewind a little bit and talk about, we will predominantly see those complaining of TMJ pain or GMD disorders will be those that are mostly predominantly women. It can be in men as well. They're just usually not the ones complaining of it. With your men, you might be treating them for something else like neck pain. Maybe they got in a motor vehicle accident and you might be seeing them for that. Our typical prevalence is 20 to 40-year-olds, although we'll continue to see a higher incidence of those over 55. So really, guys, you're going to see TMJ in those that you're treating for something else. So all of the patients that I've really treated for the most part are coming in with shoulder complaints, with neck pain, and with headaches, and you're then talking to them about what else is going on in their life and in their body. It's really very highly correlated with stress, and so those that have a very high stressful job can incorporate this. So people that are CEOs or they're in big positions of leadership and management can have a lot of TMJ, or maybe some of those that are students at the time, especially if you think about correlating those with who we're talking about. They really have that poor posture. So we're talking about that upper cross syndrome now relating into the TMJ. Why aren't we seeing referrals for TMD? Well, I would say not a lot of people are seeking out primary care from their PCP. Dentists actually are probably going to talk about this with the most, and so if you have a chance to get in with a dentist, that'd be very good. But there's also now TMJ clinics that they're being sent to, and these are, unfortunately, I would not say that this is where we're seeing high quality care with high results in that sense. There's a lot of alteration of teeth, and that might be needed at some point, but that's really lack of attention to, it might be a myofascial issue, and it might be a really big stress management issue that we're talking about. These are people that you're going to probably want some type of maybe mental health practitioner, whether it's a counselor or a psychiatrist or someone else to help them with management of stress might be helpful to keep involved with that. So primarily PTs are the ones that are treating this, but we're also understanding that this is a multifaceted diagnosis that we're talking about. What's our typical presentation? Well, they're going to more often than not complain of a headache. They can also complain of just jaw pain, meaning that they're getting maybe some sharp pain into there. They can get pressure. It might be on one side more than the other. Maybe they chew on one side because they've started to alter their chewing and not chewing on the other side. Ear pain is a common diagnosis with that, especially with palpation. So if you guys just take your hands and you start to palpate around the bottom of your earlobe as you get closer to where your TMJ is, and really give yourself some pressure in there, just check to see if you're getting any ear pain in yourself at this point. Patients are coming in with those tension headaches, so the ones that are coming up behind their skull into their forehead, and complaining of that. And a lot of that might be because of clenching of their jaw. You know, the International Association of the Study of Pain, they've done a lot of research on TMD, and they really quantify it as pain in those muscles of mastication. So remember, those muscles of mastication are our temporalis, our masseter, and then our pterygoids. So those are really hypertonic and on, and it can come on with chewing, but it can also just come on, maybe they have been clenching and grinding their teeth throughout the night, so maybe in the morning they're having a little bit more difficulty. They also define it as associated with popping and clicking sounds. So, and a lot of you right now, so if we sit up nice and tall and you open your jaw fully, so go through full depression and full elevation, go ahead and check and see if you have clicking or popping throughout that. A little bit later we'll watch a video on what that popping and clicking might be from, but there's joint sounds. The third thing that is associated is usually limited range of motion. And we're finding that with that limited range of motion, now we're starting to not see as much animation through their voice and through their communication. You're also finding that they're starting to change the way in which they eat and what they eat. One of the main things that you'll want to talk about is chewing gum, because that's a really big deal of patients, that you want them to avoid chewing gum so that it's not really aggravating them as they're going throughout their day. We talked about that most likely in women, and that we might see that. So we also want to just make sure that when we're talking with our patients that we're trying to rule out infection, so you guys know how we're making sure that there's no signs of fever and extra fatigue, and maybe if there has been recent infection, where has it been, meningitis, and then we also want to make sure giant cell arteriitis isn't a possibility as well. So when we go into our exam, the main thing that we're looking at is what is our patient's posture. So if you guys sit with that forward head posture right now and then open and close your jaw, does that seem to increase anything? So if you did your little pre-test and now your post-test, does that increase it? If it doesn't, maybe call up your mom or your grandma or your dad and ask them to go through the same thing. And let's just do a small little poll on if they are experiencing any dysfunction within their TMJ joint. We want to watch how our patient is speaking. Are they guarded? These are our patients that maybe have upper traps for days, that they have that really hypertonic posture. They might come in for neck pain, and they're the ones that are drawing that big sweeping band of fascial pain throughout that. Our detailed history is going to help us out. So again, we talked about that these patients are usually coming in for something else. So we might just have a brief discussion on TMD during our initial eval, but this might be something that also comes treatment 2, treatment 3, after you start to see results with their neck pain, but maybe something is still just residual. Maybe their headaches are staying. So we really just maybe need to dive a little bit deeper into that. So we want to make sure that we just pay attention, not only just asking with their history, but pay attention to joint noises. So if they're talking to you, can you hear popping and clicking? Or if they come in with gum, do you see any of those abnormal deviations in their jaw? And then just a quick discussion on if they feel any alterations. Do they have any pain in and around their TMJ joint? Do they have any pain up into their head, maybe causing some of that? And that's maybe coming from the TMJ. We're going to step into now looking at what else is going on cervical. You guys should be very thorough with their cervical and your glenohumeral subjective examination and then objective examination, making sure that we pay attention to that upper cervical spine. So C1, C2 with the forward head posture, we know shifts really anteriorly and they get stuck at that C1, C2 level. And so using maybe some of our manipulation can help with that level, and then thinking about that CTJ junction, that would be a great way in which we can influence this patient population right away. And then you're already thinking about your interventions and how to retrain that poor posture. We're going to take our TMJ range of motions in millimeters, or you can do also how many fingers width they can do with opening. So if your patient can only do 1 finger width and you do it at your first knuckle, really, is that is not normal. So we want them to be able to open up with 3 knuckles width of depression and have no popping or clicking or pain with that. Really, one of the main things that we're doing is quality of motion. So we talked about that. End feel, so you're going to hook into the jaw, and as they go through depression, you're going to give a little bit of joint play at the end of that. When you go through that, though, you're going to be very gentle. So when we think about grade 1, grade 2, grade 3, grade 4, you're going to want to even maybe do a half a grade just to make sure that you maintain the integrity of the joint and understand that it's a very small joint. So we don't need to give a lot of pressure with that. When we go through our end feel and we're really trying to feel, we might come along that hard end feel, and that's really that osseous abnormality. We should feel somewhere in between that springy and that capsular pattern. So understanding springy might, if it's super springy, might mean that it's displacement of the disc, and that we're really just hitting in onto that disc as it displaces anteriorly. Or capsular could be that there's some adaptive shortening into that. So we'll just want to make sure that we understand where are they at as they go through that full depression. What do we feel and what do we hear as we're going through that? And then palpation. Make sure that palpation with depression and elevation, you're really feeling what is happening and trying to figure out where in the depression cycle is there some displacement happening. Hypertonicity. So it's very important that we look at those muscles of mastication for hypertonicity. So on yourself right now, I want you just to get on top of where your TMJ joint is, and as you come down, remember your temporalis is going to dive deep underneath of there, so you're not going to be able to feel where the origin is, but if you just ride right above that and ride into your temporal region, feel on one side versus the other if you have any differences in hypertonicity of that. Okay, now let's move to the masseter. So thinking about right underneath that zygomatic arch, and you're going to start up high right underneath that zygomatic arch and just come down to your jawline. And just feel on yourself if you have any of those restrictions in there. Then we're going to try and feel your pterygoid. So that's really where that greater auricular is. There's a little space behind your ear as you kind of tuck underneath that you can hook on underneath there. That pterygoid really is the one that can cause some of that sharp ear pain as you dive into there. So go ahead and palpate on yourself, see if you have any hypertonicity or myofascial restriction as you go through. It's important to do this with your patients as they go through depression and elevation to feel what each of those muscles is doing. Is one firing all the time? Is it not firing enough? There's usually some kind of symmetry that is off between both sides of the jaw. So you want to make sure you don't just focus on where your patient might be complaining of pain, but also really understanding what does all those muscles feel like as you're going through that. So let's just, we just went through this, but let's just review. We're going to watch a brief video. It's 3 minutes on just reviewing what happens with that disc displacement and really watching as we go through that jaw movement, what happens. So let's get set up here.
Mandibular joint, the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
All right, so just a nice overview on what our different dysfunctions can be and look like. So we're going to just kind of keep that in mind as we go through the rest of our short lecture. So what you'll see in patients is as they go through elevation and depression, as they go through depression, you might see a deflection in two different ways. You might see a C curve or an S curve. This might help us with understanding what's going on. So if you see that C curve, it can be that it's that same side is really not working very well and maybe has some hypomobility, more joint dysfunction on the same side. So we'd want to consider, what does that look like? Do we need to do maybe a manipulation on that side? A deviation or an S curve might mean more muscle imbalance. So we're going to understand that. We also want to understand that limited opening might be with early deviation. So if that's that first very small, it might be that there is internal derangement without reduction, meaning that it's deranging but it's not reducing back into that side. And that might be that we're seeing that protrusion, retrotrusion of the disc, and will just cue us in that we need to do some more work, maybe with releasing some of the muscles of mastication, and then maybe some retraining and neuromuscular retraining with more resistance through the joint cycle or through that elevation and depression. As we go through, we're going to talk a little bit more about what are these clicks telling us. Because our patients might not know if you ask them, what is early, intermediate, late? And that's really where you're going to either put them in supine or leave them in sitting, because sitting might be one of their more functional areas where you want to look at that popping and clicking to see what is really happening. And what we're going to understand is that if it's an early click, so if we remember back to that video, if that displacement is happening early, we might have a small anterior disc displacement. If the click is happening late, it might be that that disc is really displacing further into that cycle. And then we saw that now that if that keeps happening over time and that disc stays out, we can get scar tissue that lays down, and we might now be talking about more of a pseudo disc where we're just trying to help them with that stress reduction, myofascial release. You can do some integrative dry needling into the area, and still I would try your manipulation to see if that helps with repositioning. If we have just inconsistent or maybe it's soft popping, this can be more of a neuromuscular re-education issue where we have muscle imbalances. We have one muscle that might be overactive and working harder than the other muscles around that TMJ joint. It might be also caused by some ligament dysfunction, or maybe there's some articular dysfunction that is more pathological, and so we'd have to just examine, make sure we do a really thorough examination with that. And also, really, this is a population where you want to make sure that you are trying to measure if what you're doing is actually making a difference, and if it's making a difference long term. You don't want to do a lot of intervention into that system, because usually the acuity level or the irritability level can be pretty high, and we might not know that in treatment. It might feel very good, but then later on you've just flared them up. And so I would limit how many manual interventions you're doing in one setting, and maybe just consider that you want to do maybe 10 to 15 minutes and work a lot more on posture and neuromuscular re-education. So let's just talk about our different buckets that we're going to put them into. This would be, where's our PT diagnosis? So we're going to talk about joint dysfunction with mechanical derangement. So that would be that more, we're going to go down the road of we want to do more manipulation with this type of group. This might be a minor, that they have a gradual onset of symptoms after minor physical activity, and they just get better with rest. And then the second bucket we would say is that masticatory muscle disorders, and most patients will be into this bucket, or they'll actually be in both. So it's not necessarily that you're just going to have a brief, quick joint dysfunction without any of those hypertonicities and myofascial restrictions, you're going to often be treating both of these, and you'll probably put both PT diagnoses on there. What you want to come to decide is if it's more of a muscle disorder, you're going to prioritize those hypertonic muscles prior to doing your joint mobilization or joint manipulation. And I would say the 80% of our cases are more, you're going to stick with your myofascial first, and then you're going to add in your manipulation as you start to see some improvement through that. Remember, we're going to do our retest on where are their symptoms at, how does their depression look, are they still having deviations through that as you go through your interventions. We can do different types of joint loading tests. So we can do that joint dynamic loading test where they forcefully bite on a cotton roll or a tongue depressor. I wish you guys had that at home right now to try, but we will make sure that we do that in lab, just understanding that you want to do it on one side versus the other to see how does that feel when they really now get into that elevation. Remember, the elevation should be a bony contact of the teeth on themselves, and it should be equal on both sides. If the patient has contralateral pain, they're positive for contralateral intracapsular pathology. So meaning if I bite on the right, but I get pain on the left, now I'm thinking that it's more capsule. If I bite on the right and I get pain on the right, now I can think that it's more myofascial dysfunction. Still pretty limited in if these are phenomenal tests or not. There's no gold standard currently for us right now. But let's just go back and think about Maria. I know that we've kind of forgotten her, but remember she had pretty significant pain with chewing. She's had pain for a while. She has neck pain. She also has headaches. So what are 4 interventions throughout this lecture that you could consider for Maria? What we'd like you to do is write that down on a sheet of paper or a half a sheet of paper and bring it with you to class on Tuesday morning. And just be prepared to have a discussion on why you might choose those said interventions for Maria. Thinking about not only her TMJ dysfunction, but also maybe considering what types of exercises does she need to do as well because of her forward head posture. So this is how we're going to end. TMJ can be really rewarding. You can help people out with lots of different functions in life that they want to do, but it can also be exhausting because it is such a stress management type of issue and a postural retraining issue as well. So our take-home message for you guys is don't neglect this joint as you're going through your others. If you're talking about neck pain patients or shoulder patients that complain of that, make sure that you're talking about that TMJ joint. And then also really trying to help those people get into a beautiful exercise program and postural retraining and just motivation to move more and to decrease their stress and drink more water. So I think all of you guys could probably benefit from that, and you probably know someone that can even right now. So maybe even give your family and friends a little gift and help them out with how they can go about helping their TMJ joint. And thank you guys for listening. And you guys did a great job. Make sure you come to class with that sheet of paper, and we'll have a more detailed discussion on the treatment of our patients with TMJ dysfunction.